Childbirth is a remarkable process, but sometimes things don't go exactly as planned. One of the rare but serious complications is something called shoulder dystocia. This sounds complicated, but it simply means that after the baby's head has been born, one of the shoulders gets stuck behind the mother's pubic bone. This can be a very frightening and dangerous situation for both the mother and the baby. It requires quick thinking and skilled action from the doctors, nurses, and midwives in the room. They need a reliable method to resolve the situation safely and efficiently without causing harm. To handle this specific problem, medical professionals have a very effective technique called the McRobot maneuver. It's not a surgical procedure and doesn't require any special equipment. Instead, it is a specific way of changing the mother's position to help free the baby's stuck shoulder. The beauty of this maneuver lies in its simplicity and its power. It is often the very first thing a medical team will try when they encounter shoulder dystocia, because it is so effective and carries a very low risk of complications when performed correctly by trained staff. The maneuver was named after William A. McRobot, a British obstetrician who described it in the late 20th century. He observed that by changing the angle of the mother's pelvis, it was often possible to dislodge the baby's shoulder without needing to apply excessive force to the baby. This simple repositioning can create just enough extra space inside the pelvis for the shoulder to slip past the bone. It is a testament to how clever anatomical adjustments can solve complex physical problems during the birthing process, making delivery safer for everyone involved in this critical moment. Understanding this maneuver is a fundamental part of training for anyone involved in delivering babies. It represents a cornerstone of emergency obstetric care worldwide. While we hope it's a skill that is rarely needed, being prepared for that one instance can make all the difference. It turns a potential crisis into a manageable situation, protecting the baby from injury and the mother from a prolonged and difficult labor. The goal is always a healthy mother and a healthy baby, and the McRobot maneuver is a key tool in achieving that outcome when challenges arise. So, how is the McRobot maneuver actually performed? The process is quite straightforward and can be broken down into a few clear steps, all focused on repositioning the mother. The first action is to have the mother lie flat on her back. This is often the position she is already in, but ensuring the back is flat, without pillows propping up her head or upper body, is an important starting point. The medical team will then ask her to stop pushing for a moment while they get her into the correct position to help her baby. The next and most critical step involves the mother's legs. The midwife or doctor will ask the mother to bring her knees up towards her chest as far as she can. It's a movement that is often described as bringing the thighs up against the abdomen. Usually, two assistants, one on each side of the bed, will help the mother hold her legs in this position. They gently but firmly flex her hips so her knees are pulled back towards her armpits. This hyperflexion of the hips is the core component of the entire maneuver. This specific leg position does something quite remarkable to the mother's anatomy. By flattening the natural curve in the lower back, known as the lumbar lordosis, and slightly rotating the pelvis, it effectively widens the pelvic outlet. It doesn't actually make the bones bigger, but it changes their alignment in a way that creates more space for the baby to pass through. This subtle shift is often all that is needed to allow the stuck anterior shoulder to pop out from behind the pubic bone, resolving the entire issue. Once the mother is in the McRobot position, the doctor or midwife may also apply gentle pressure just above the mother's pubic bone. This is called suprapubic pressure, and it is designed to help push the baby's stuck shoulder downwards and sideways, guiding it under the bone. It is important that this pressure is applied by a trained professional, as pressing on the wrong part of the abdomen can be harmful. This combination of the mother's new position and the gentle external pressure is a powerful 1-2 punch against shoulder dystocia. The importance of the McRobot maneuver cannot be overstated, primarily because it is a direct intervention to prevent serious harm to the baby. When a baby's shoulder is stuck, the umbilical cord can become compressed between the baby's body and the mother's pelvis. This compression can cut off the baby's supply of oxygen and blood, which is a medical emergency. Every second counts in this situation, and the speed and effectiveness of the McRobert maneuver can restore that vital flow, preventing potential brain damage or even more tragic outcomes for the infant. Furthermore, this maneuver is crucial for preventing physical injuries to the baby during a difficult birth. If a shoulder remains stuck, there is a risk of nerve damage to the baby's arm and shoulder, a condition known as brachial plexus injury. This can lead to weakness or even paralysis in the arm, which can be temporary or, in some cases, permanent. The McRobert maneuver helps to avoid the need for more forceful pulling on the baby's head or neck, which is a primary cause of such injuries. It provides a safer, gentler solution to a very physical problem. For the mother, the importance of this technique lies in avoiding a traumatic and complicated delivery. A prolonged second stage of labor due to a stuck baby can lead to maternal exhaustion, severe tearing, and an increased risk of heavy bleeding after birth. By resolving the issue quickly, the McRobert maneuver helps to reduce these risks, allowing the birth to proceed more smoothly once the shoulder is free. It helps maintain the mother's physical well-being and can also reduce the psychological trauma associated with an emergency birth situation. Finally, the maneuver is a vital first-line response because it is non-invasive. Before considering more drastic measures like surgically widening the birth canal, known as an episiotomy, or even more complex internal maneuvers, doctors have this simple, safe, and often highly successful option. Its high success rate, estimated to resolve up to 90% of shoulder dystocia cases, means that in most situations, no further, more risky interventions are needed. This makes it an essential skill that protects both mother and baby from the escalation of a birth complication. For doctors, nurses, and midwives in training, reading about the McRobert maneuver is one thing, but truly understanding its mechanics is another. This is where modern teaching tools, like three-dimensional models and simulations, become incredibly valuable. Using a life-sized plastic doll of a baby and a model of a female pelvis, instructors can physically demonstrate exactly what happens during shoulder dystocia. Trainees can see with their own eyes how the doll's shoulder catches on the plastic pubic bone, making the abstract concept very real and easy to grasp. These three-dimensional models allow for hands-on practice in a safe, controlled environment. A student can physically perform the maneuver on the model, repositioning the mother model's legs and seeing how that simple action changes the pelvic angle and releases the doll's shoulder. This tactile learning reinforces the steps in a way that a textbook never could. For example, a basic scenario might involve a trainee delivering the model baby's head, then being told the shoulder is stuck. They must then correctly call for help and guide their team to perform the maneuver, seeing the immediate physical result of their actions. The use of these models helps build muscle memory and confidence. In a real-life emergency, there is no time for hesitation or for trying to recall steps from a book. Having practiced the maneuver many times on a doll, the medical professional can act instinctively and efficiently. They understand not just what to do, but why they are doing it. They have seen the anatomical cause and effect. This preparation is critical for ensuring a calm and competent response when faced with the high-stress reality of a genuine shoulder dystocia event in the delivery room. In conclusion, continuous training and practice of the McRobert maneuver are fundamental for all maternity care staff. It is a simple yet profoundly effective technique that saves lives and prevents lifelong injury. By embracing modern learning aids like three-dimensional dolls and pelvic models, we can ensure that every doctor, midwife, and nurse is not just familiar with the procedure, but is truly masterful in its application. This commitment to practical, hands-on education is one of the most important investments we can make in the safety and well-being of mothers and their babies everywhere.